My name is Ben Thompson, the National Medical Director for Workforce Development and Strategy for Gentiva. Today I'll be talking about alcohol use disorder at the end of life. The Center to Advance Palliative Care defines palliative care as specialized medical care for people living with a serious illness. This type of care is focused on providing relief from the symptoms and stress of the illness with the goal of improving quality of life for both the patient and their family, biologic or chosen. Palliative care is appropriate at any age and at any stage of a serious illness. Hospice care is appropriate for patients with a life-limiting illness and an expected prognosis of less than 6 months if the conditions continue on their expected course. Alcohol use disorder is a chronic condition characterized by an inability to control alcohol consumption despite negative consequences. This topic is critical because patients with alcohol use disorder often face complex physical, psychological, and social issues that impact their quality of life, as well as the quality of end-of-life care that they receive. At the end of life, patients with alcohol use disorder may present with advanced liver disease, cancer, or other terminal conditions exacerbated by chronic alcohol use. Patients with alcohol use disorder may also approach end of life due to a condition unrelated to their alcohol use. Estimates about the frequency of alcohol use disorder in patients with life-limiting illnesses are challenging due to national inconsistencies in screening for alcohol use disorder among hospice and palliative care teams. We know that 6.3% of adults in the United States will develop alcohol use disorder over the course of their lifetimes, and all of those patients and all of us will eventually die. Patients with known alcohol use disorder often experience stigma when receiving end-of-life care, which can complicate care delivery and family dynamics. Additionally, alcohol use disorder is linked to higher rates of social isolation, housing challenges, and estranged relationships, all of which magnify the complexity of providing patient-centered end-of-life care. Alcohol use disorder and end-of-life care poses significant risks in multiple domains. Physically, patients may experience worsened pain, delirium, or hepatic complications, which complicates symptom management. Alcohol withdrawal syndrome is a major concern as it can lead to seizures or delirium tremens, especially in patients with limited physiological reserve. Alcohol use disorder and continued alcohol use can exacerbate anxiety, depression, or cognitive impairment, making it more difficult to engage in meaningful end-of-life discussions. These patients often face stigma from healthcare providers and their family, which can lead to undertreatment of pain or other symptoms. The emotional toll of fractured relationships or guilt can also heighten psychological distress. For clinicians, challenges include balancing patient autonomy with safety, particularly when patients continue to use alcohol against medical advice. These factors can increase caregiver burden and contribute to moral distress among providers. The decision to stop or manage drinking at the end of life depends primarily on the patient's goals and their prognosis. Some patients may view their alcohol use as unproblematic or a source of comfort at the end of life, while others will see alcohol use as something to beat before they die. Decisions regarding initiation of medications for alcohol use disorder, further education, and a plan regarding continued drinking should come from a thoughtful conversation between the patient and their clinician while respecting a patient's autonomy. If a patient wishes to continue drinking, the clinician should keep that in mind while making decisions regarding a plan of care, including medication management and setting of care. Managing alcohol use disorder and end-of-life care requires an interdisciplinary, patient-centered approach. First, assess for active alcohol use with a screening tool like the Alcohol Use Disorders Identification Test or audit, and manage withdrawal with tools like the Clinical Institute Withdrawal Instrument for Alcohol Scale, or the CYAR. For patients experiencing active withdrawal, benzodiazepines can be titrated to manage symptoms safely, with dosing adjusted for frailty or hepatic dysfunction. Lorazepam is generally considered safer in patients with hepatic dysfunction because, Unlike other benzodiazepines, its metabolism does not require cytochrome P450 enzymes. Management of anxiety in patients with alcohol use disorder at the end of life depends on prognosis. If the patient has a prognosis on the order of months, it would be reasonable to initiate therapy with an SSRI or an SNRI. If their prognosis is shorter, consider benzodiazepines for anxiety while being mindful of the previously discussed cautions. Pain management is critical for patients experiencing pain at the end of life, but opioids must be used cautiously due to the risk of respiratory depression in patients with liver disease and those continuing to drink alcohol, giving compounding depressive effects on the central nervous system. Fentanyl, methadone, buprenorphine, and hydromorphone appear to be safer alternatives to morphine and oxycodone for patients with hepatic impairment. It is imperative to consider non-opioid management of pain in all patients, but especially those with alcohol use disorder. Adjuvant pain management strategies, such as nonsteroidal anti-inflammatory medications, steroids, acetaminophen with a 2-gram daily limit, SNRIs, and gabapentinoids should be considered in a patient-dependent fashion. Non-pharmacologic interventions are equally important. Social workers and chaplains can address emotional and spiritual needs, helping patients and families navigate guilt or reconciliation. Brief motivational interviewing can support patients who are ambivalent about reducing alcohol use. Hospice and palliative care teams should also address family dynamics, offering support to caregivers in clinical settings, like skilled nursing facilities or hospitals, or in the home, who may feel overwhelmed. Ethical considerations, like respecting a patient's choice to continue alcohol use, require clear communication and documentation to align care with their wishes while minimizing any risks of potential harm. In summary, alcohol use disorder at the end of life demands a nuanced approach that balances symptom management, withdrawal prevention, and emotional support. Key takeaways include using standardized tools to assess withdrawal risk in patients with life-limiting illness, tailoring pharmacologic and non-pharmacologic interventions, and prioritizing patient autonomy in care decisions. As clinicians, we must advocate for these patients, reducing stigma and ensuring compassionate care. My call to action is to incorporate routine screening for alcohol use disorder or heavy alcohol use in patients approaching the end of life, engage interdisciplinary teams early, and foster open discussions with patients and families to align care with their goals. By doing so, we can enhance the quality of end-of-life care for this vulnerable population.